Top Med Talk.
Hello, welcome back to Top Med Talk. I'm here again at the Evidence Based Perioperative Medicine EBPOM World Congress in London, United Kingdom. I'm Andy Cumpstey, and I'm delighted to be joined by a couple of, familiar and new faces to Top Med Talk, which is always good. Imogen Fecher-Jones and Andrew Davies. Welcome to joining us here in London. Thank you.
Yeah, thank you, Andy. And it's really fantastic to be back at EBPOM again this year. So my name is Imogen Fecher-Jones, advanced clinical practitioner, currently undertaking a doctoral fellowship at the University Hospital Southampton.
Andrew Davies, upper GI surgeon based at Guy's and St Thomas's Hospital in London. My involvement with this has been through the variety of initiatives driven by Imogen on surgery schools. So thank you for the invitation. Look forward to taking part.
So Imogen, we've talked about surgery schools before on Top Med Talk. I think we did one of these at EBPOM last year about surgery schools. But just for our listeners at home, can you remind us what we're meaning by a surgery school and what that concept is?
Yes, absolutely, Andy. Yes, I think it was a year ago we sat here and had a very good discussion about the Perioperative Quality Initiative. So the definition that we came up with through the process of that Delphi consensus was that surgery schools, although they do come in many guises, in the purest form, they are a group preoperative education session that encompasses behavior change techniques to help improve patients physically and emotionally prepare for surgery.
And can you give us an idea of how common or rare these are?
We know in the UK that surgery schools are starting to become standard care in many places. However, there are still a vast number of places that aren't able to offer surgery schools as part of their elective programs. But in 2001, there was some guidance come out from the Centre of Perioperative Care, which recommended that actually any patient undergoing major elective surgery should be offered a surgery school. So we're hoping through this initiative we're talking about today and the POCI that we've now published that we'll be able to support clinicians and the MDT to be able to deliver more surgery schools, both nationally and internationally.
And you've already hinted about my next question, but so you touched on the POCI or the Perioperative Quality Initiative about surgery schools, which we discussed last year. But just because some places are doing surgery schools doesn't mean it's the right or the wrong thing to do, is it? What's the evidence behind it, I guess, is the question. And on Top Med Talk, we know we're always pushing evidence-based medicine. And you've done a lot of work in this space already, haven't you?
Yes, that's right. So, I've been delivering surgery schools now clinically for the best part of a decade, which is slightly scary. So I've obviously been studying it throughout that time as well. And now I'm in a position to be able to study it as part of my PhD. But yes, so the evidence behind surgery schools are that they have an impact on many different patient outcomes, both clinical and patient-centered outcomes. In fact, we published a systematic review last year, which looked at the outcomes of surgery school and identified 43 different types of outcomes. So we know that they do have an impact on the patient. And we also know they can be really useful as a universal form of prehabilitation, so to get that ball rolling. And some of those patients who attend surgery school are likely to go on and make behavior changes as a result. So we know that they're useful, and patients tell us how much they enjoy attending them. And that's the important thing as well.
And Andrew, I'm going to bring you in at this point. So before we get into the nitty-gritty about toolkits and evidence and things we're going to talk about a bit later, just from a personal experience as a surgeon, do surgery schools matter and do they change your practice?
I think if this comes back to one of the fundamentals of what Imogen was just saying, which is there is the principle of the things, in theory, and then there are the deliverables. And a bit like lots of these things, enhanced recovery, rehabilitation, surgery schools, lots of institutions will probably say, we do this or we try to do this. And actually, how successfully those are being delivered and how consistently they're being delivered is one of the challenges. And so I think one of the great things about these processes is improving standardization. And from a personal perspective, having not been involved for a decade in surgery schools, our institution has, is relatively in its infancy in that regard, but having some guidance to take to clinical managers on best practice is really helpful. It's very helpful leverage for us. We're not just asking for money for services, we're going with the backing of a multidisciplinary consensus, and that really is important to us.
Brilliant. And that leads us on nicely to this development of the toolkit. So you want to give us an overview of what the toolkit was aiming to do, where the idea came from, and who sort of drove that on a national level here in the UK?
Essentially, we'd done all the POCI work, we'd done the literature review, and there was then a sort of gap between what we knew and the evidence and the experiences and guidance, but then the implementation piece just hadn't been covered. And so This was something I was thinking about, but I'm only partway through my PhD, so it was sort of a longer term project for me. And then I was approached by NHS England and the Perioperative Optimisation Working Group, which is led by Ramani. They suggested this idea that perhaps we'd like to work on a toolkit together, which was wonderful to be asked and been really great to be able to see this through. So we started on that last year. And then the first part really of developing that toolkit was bringing all the stakeholders together and establishing what they wanted essentially and what it needed to include. And Andrew was one of those stakeholders, so perhaps you can talk a little bit more about that.
Yeah, well, I was obviously very flattered to be involved. It was on the background of some work that we'd all been involved in the rehabilitation space, which then went on to the POCI on surgery schools. And I think one of the things that's been really successful and as a great credit to Imogen is the way that the process is built from a baseline of agreeing that consensus through that POCI process, which at times is exhausting and time consuming, but at the end of it, the product is, I think, really very valuable. And then moving forward into how that's implemented. And the toolkit was, to be honest, when we started the process, I don't think any of us who were joining those first online meetings really knew what that was going to look like. But it starts with the basics of defining what is agreed as a surgery school, and then moves very logically through a kind of planning phase and then an implementation phase, and then finally how units would evaluate that intervention. So it's very logical. Personally, the use of case examples, the provision of literature to support managerial cases, it probably saves tens, if not hundreds of hours worth of preparation. There's no point in every individual unit in the country all going through this process. Actually, Imogen and the group that she's led largely delivered most of that for us.
I think it's really worth emphasising just the breadth and variety, both in terms of specialty, but other backgrounds as well, that were really involved in that stakeholder group. I'm not asking for a list of names here, Imogen, but could you give us some examples of different roles people have played in that group and maybe some of their backgrounds, people that you pulled in to really help develop this toolkit?
Yeah, so it was really important to us that it was very multidisciplinary, all of the stakeholders, to get a real breadth really of experience. And that the core team came from the POCI, so the surgery school consensus work that we'd done, but that was an international piece of work. And obviously for this NHS England-based piece of work, it needed to be UK-based people. So we sourced them through literature that's been published on surgery schools and researchers who I knew were active in this space, and also went on recommendations of others as well, and also looked for places in the country that were really leading. So Manchester, for example, they have a really strong surgery school that's been going for, over a decade now, I think. So we just tried to pull as many people as possible that would just give a diverse range of views. So that included OTs, physiotherapists, we had some gerontologists, we had psychologists. Of course, the behaviour change element is really important that they are able to contribute. Unfortunately, we weren't able to get much in the way of representation from primary care, so we didn't have any GPs. That wasn't for want of trying, it just was tricky to bring them in. We had surgeons. I'm trying to think who else we had involved now. Anaesthetists, obviously. That's probably about it. But up until this point, no one else has attempted to do this. It was quite a novel piece of work. But one of the researchers I met along the way, Anna Anderson, who's based in Leeds, she's actually done something similar with joint schools and orthopedics and surgery schools. So, and again, she's the only one that's done consensus and then gone on to write some implementation plans. So having her on board as well was hugely valuable.
And patient engagement as well, Imogen.
Oh, yes.
You get a lot of work on patient engagement as part of the POCI, but also the toolkit, didn't you?
Thank you for reminding me about that, because actually that was also very central to what we were doing with the POCI recommendations. My patient and public engagement group there were very vocal about what they thought of our guidance. And then all of the patient-facing materials that we have developed for the toolkit have all been through our PPI groups there, and we've had lots of feedback and be able to make changes as well to improve them.
So that's probably a good point to pick on. Who is this toolkit aimed at? Is it aimed at the patients? Is it aimed at clinicians? Is it aimed at both? Is it aimed at the managers, like we talked about earlier?
There were lots of discussions about the role of patient engagement in these processes, because both the sort of POCI and the toolkits, I think I'm not wrong in saying, historically and principally are aimed at centres, clinicians, allied health professionals who are trying to deliver these interventions. And to some extent, if you then try to aim a document also to patients, lots of things have to change, the nature of the language and what you're discussing. So you don't want to lose the overarching aim by trying to target too many people. There may well be a role for a series of documents that are actually aimed specifically at patients. And clearly that's an important part of the information giving that we give them as part of surgery schools. But these documents principally are aimed at clinicians, allied health professionals who are trying to develop these services. Also managers, the whole wider team that we would be encouraged to get involved in setting up a surgery school.
I come back to one of your earlier points, but I think that question about the consistency and following the evidence base that Imogen mentioned is also really important with this toolkit as well, isn't it? Because there's probably a group of hospitals, centres, clinicians out there that will hopefully be able to use this toolkit to help them start from scratch and develop new surgery schools. Hopefully this will follow on from the POCI to help centres that are already delivering surgery schools try and bring a bit more consistency and standardisation amongst what we're all doing up and down the country.
Yeah, absolutely. And what came out of the literature review that was published last year in BJ Open was that there is no consistency with surgery schools. Everybody does something slightly different. Well, not slightly, quite a bit different in some cases, because of course there will be local adaptations that need to be made, but essentially there needed to be a core framework, because again, it makes it very difficult to measure outcomes when everyone's teaching something a little bit different and each intervention is different in itself. So yeah, from that point of view, that's really important.
So I guess we should get into the nitty-gritty. What does this toolkit include? What does it say people should be doing?
I think Andrew's already talked about sort of the overarching document is this instruction manual, I suppose, which walks you through the process from planning how you might implement your surgery school, what your intervention might look like, through to actually delivering it. So that framework sits over the whole piece. And then there is this bundle of resources which we're hoping are going to be particularly useful, because as we said, we don't want people to be reinventing the wheel every time. We don't want them to start from scratch. We want them to just take it off the shelf and have it almost ready-made to run with, because that's just going to help our busy clinicians get it to patients quicker. So the resource bundle is a fair bit of signposting to what, the evidence is and the best bits of evidence that are out there, including the POCI work. But also we have a patient information document that's very generic. It's a Word document. You can download it. You can edit it to fit what you need for your trust and personalize it in the way that's best for you. But it's ready to go. And it's a fair number of pages, probably about 20 pages or so, but it's everything in there that surgery school is. So it's all that information that patients have told us they want, supporting information. They actually still like a written booklet to take home and be able to review at leisure, so to speak. So that's there, ready to go, because those are things that can take so long to develop. We've also worked on a video, sort of a snapshot video of quick recovery techniques such as the drinking, eating, moving, getting good rest after surgery. And we've developed that so that people can plug that straight into their surgery school. And that's another chapter they don't need to teach. They can just show the video. And then on top of that, we've got a cost benefit analysis that's been done by one of our collaborators at the Department of Health, looking at weighing up the costs for, surgery school versus no surgery school, and looking at the potential clinical outcomes that could be improved, including length of stay. There is some lists of educational content that could be included. That's based on the POCI. So all of the educational content that was recommended through the Perioperative Quality Initiative we've now translated that into sort of an agenda, I suppose, of what you would include in your surgery school. And then we've got some other supporting governance documents, because again, these are things that take clinicians time to write and are quite painful at times. So, a standard operating procedure, an equality impact assessment form. And lastly, a sample or example patient satisfaction questionnaire as well, because finding out what our patients think of these interventions as well is so important to be able to develop them and make the changes that they need so that it fits their needs.
Fantastic. And I should pick up on, you mentioned the drinking, eating and moving piece of work that's gone alongside this. So we'll be doing a separate podcast recording with Top Med Talk with a team that have been developing a similar toolkit in parallel to this, to talk about that in more detail. And I think the video that you mentioned is going to be really important across both of those toolkits. So definitely worth highlighting that, and look out for our other listener that will be coming on this topic soon. And just want to come back to you briefly. So there's a huge amount of work gone into this from yourself, Imogen, and others. There's a huge amount of documents there. If you were either a clinician or a manager in a prospective trust, either with a surgery school or without it, where do you start with this document? Do you pick it up from scratch, and then what happens next? How do you sort of foresee this coming into practice or changing practice going forwards?
I mean, the toolkit kind of does it for you. That's one of its great charms. It starts from the very beginning. So the underlying definition, and then the sort of basic principles that have been agreed. And then in that, early planning phase, it's often about people. It's about putting the right group of people in a room together, which involves everybody from a whole multidisciplinary team of clinical caregivers all the way through to hospital managers, of course, patient involvement. And one of the things I think is quite difficult to achieve with any of these documents is, how do you provide sort of generic advice that's appropriate for everybody, whilst allowing centres and places just the flexibility to adapt that, to themselves. And there are a number of sort of areas, I guess, where there were quite a lot of discussion through the meetings. Obvious ones being things like, should a surgery school be delivered to a very specific group of patients all having exactly the same operation, or should this be a much more sort of generic first principles that you could deliver to a group of patients having a very wide range of operations. And then it was really interesting listening to all the participants. There were a whole range of views. And I guess that the answer is it's different places will have their own solution, but all of those options are very much workable within Toolkit.
Brilliant. Imogen, you said, and quite rightly highlighted, this was done with a UK focus. It was funded by the UK's National Health Service with a sort of UK healthcare system in mind. I think it's fair to say that we're all hoping the applicability is much more wide-ranging than that, isn't it?
Absolutely. Well, more than hoping, I know, because I get inquiries from all over the world anyway. From the POCI experience, I could see how much engagement there was from many different countries, from Canada, from Australia, from Italy. So yeah, I'm really hoping actually that when it is available, the impact will be much further afield.
I should say we're recording this, as we said, at the World Congress, the Evidence Based Perioperative Medicine World Congress in London. And we haven't actually been given the official release date for this document yet, which is why we're being a bit vague about that. But we know it's coming out soon. And when it does come out, we'll be able to link to it in the show notes. So we can put that link down below. But thank you both for coming in. Just to finish off, what's next to watch in this space then? What's the next stage in surgery school work and development on the horizon?
Well, I'm hoping Andrew's going to get a surgery school.
Yeah, it's the plan.
For me, I mean, I'm partway through my PhD, and it finishes with a feasibility study looking at the effectiveness of surgery schools in behaviour change and rehabilitation. So I'm very much hoping to go on and do a fully powered trial as a postdoc in the future. So that's on my skyline. But I mean, I think more broadly it is just about measuring the impact and looking at whether surgery schools are starting to spread out, and also looking at whether there is a better consistency when people, if only people would write about them more. And I that's the plea here, that if you do develop a surgery school, please write something up about it so that I can see what's happening. And yeah, to be able to measure the impact that these toolkits are making.
Yeah, well, picking up on that point, I think one of the things that we have learned through trying to introduce things like rehabilitation is that if you don't record your own outcome data, it becomes very difficult 1 or 2 years down the line to justify ongoing managerial investment. So one of the last sections of the toolkit is about evaluation. And so, an important part of that is evaluating feasibility and compliance and patient views on what they're going through. But then there are other important things which often come back to finances, and it's all those clinical outcomes, morbidity, mortality, length of stay, and all the other surrogates. And so it's one thing introducing a program, and it's another thing having the resources to properly collect data, prove the concept, because ultimately that's what gets into the literature. That's what helps others to develop it. So I think it's data collection, I'm afraid, often comes back to the same thing.
It always is. And as we've always said on Top Med Talk, but the power of conversation, it's always about that evidence-based medicine. So you're absolutely right. That data collection is key. And I think we can all foresee a huge number of medical student, resident projects in the future looking at different aspects of this. But hopefully this toolkit will be a really useful addition to those people's armories. So thank you both for all the effort you've put in developing it. Thank you for coming and giving us some time and sharing your time with Top Med Talk today.
Thank you. It's been great.
Yeah, pleasure. And as always, you can hear this podcast on our website, on our apps, on podcasters of choice. We're available on social media, on Blue Sky, LinkedIn, X or Twitter, Facebook, Instagram, YouTube. We're available on them all. So give us a thumbs up, hit subscribe. It really does make a difference. And most importantly of all, thank you to our sponsors who are BD and GE this year, without whom we couldn't keep bringing Top Med Talk free and open access to the world. Thank you both for joining us.
Thanks, Andy.
Thank you.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook, and X. Also, it's important to remember that Top Med Talk is the broadcasting arm of EBPOM, Evidence Based Perioperative Medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.